Good evening, everybody, and thank you for joining in on time. We've got the room filling up, I think, quicker than we can actually accept. So wonderful to see this. A very, very warm welcome to this three-part webinar series brought to you by Signia Healthcare Academy along with Nurse India. This is part of, this is really Thankam's passion towards patient safety, and on the occasion of Patient Safety Awareness Week, she's conceptualized and curated this series on really, nothing theoretical, but really all of the practical issues that young nurses face at their hospitals and that nurse leaders constantly strive to eliminate or minimize. And, it's going to be a wonderful three-part series with three industry leaders on 21st, and I'm going in reverse order. On 21st March, we have simulation-based RCA or root cause analysis. That's going to be very interesting with the simulation angle thrown in. And we have, that session is being curated by Tankam Gomez and Dr. Jaideep Herbert from Vidyanta. On 19th March, we have again a very interesting session called The Hidden Iceberg Near Misses. It's that, that 1% or 0.01% gap sometimes that determines, safety. And there we have another acclaimed speaker, Dr. Jyoti Clara Michael, ex-IHH and now founder of HealthBridge. And of course, today we kick off the series with the one and only Thankam Gomez. And the topic is so interesting, it even drew, someone like me who's really not connected with day-to-day nursing. And it's today's topic is non-negotiable nursing practices for patient safety. I loved the topic as soon as I heard it, and I'm sure the audience will also enjoy it. So without further ado, handing over the mic to Thankam to take you all through the non-negotiable nursing practices for patient safety. Learn, enjoy, and spread the knowledge. Thank you. And over to you, Thankam.
Thank you, Indrani. Thank you very, very much. I am very honored and I'm very happy to be, partnering with Nurse India and bringing such practical, relevant, solutions or discussions, webinars for nurses. And I am super excited always to talk very relevant, you know, points. I don't. Uh, Gyan or knowledge anybody can get, that's not a problem. But translating them into actions. So I've been a nurse for over 40 years, of many of you already. In my 40 years, I learned a lot during the journey. And I believe that it is my responsibility to share what I learned and what I had been telling young nurses that what do we practice day in and day out to make sure that we don't get caught in some errors which we didn't want to do. I don't think none of us, any of us, will ever come to hospital saying that, today I am going to hospital and I make one mistake today. I don't think so. It is always that we want not to make any mistake with our patients and we want to be safe. I always believe that safety of the patient is through safe practices. That is why all the protocols and procedures are being written to ensure that our nurses practice safely so that they don't get into trouble just because a mistake happened by mistake. So, with that thought, I thought I will put together some points that I personally believe is very critical for any student or nurse to be sure that we don't make any mistakes. So that's my presentation, and thank you uh, for being here today in such large numbers and on time. For that makes me very glad. I think that there is great hope to improve our patient safety. So thank you for being here, all of you. And as Indrani just mentioned, we are doing a three-part series, and this is what it is. And today we are going to talk about non-negotiable safe nursing practice, patient safety. And I would, I'm just showing you the picture so that tomorrow also you'll come and listen to Dr. Jyoti Clara Michael about the hidden iceberg, the near misses, the power of the near misses is very important. And then very unique discussion on 20th, 21st rather, not on 20th, 21st. This is coming from the simulation principles. So while I was attending the SimCon in Delhi, then while I was sitting and going through various discussions around simulation, I thought, RC is something that all nursing heads, quality, everybody together keep doing for various things that happen, unfortunately, in the hospital. So I thought, why not use simulation? And that might give us, more insight into what is happening, why is it happening, what can be done as well. I will request all of you that please keep your questions, etc., to the last. Let's finish with the discussion, and I will. Indrani, are you there? Hello,
I'm
Indrani.
there, yes.
Can you just admit people? There are 11 people waiting.
Yeah, yeah, sure.
Thank you. So, ladies and gentlemen, my dear friends, I want to start with a disclaimer. These non-negotiable safe nursing practices, they are based on my experience. They reflect my personal approach to patient safety, quality care, my personal leadership approach also. And I would request all of you to reflect. And you may have more things as per your experience. Feel free to add to the list. But I am going through some of the most critical points I always used to tell my nurses that, what are the things that you just cannot take a shortcut or just cannot give an excuse. So this is what we are going to go through today. We'll discuss about burden of patient harm. We will discuss a real life incident. Then we will talk about the safe practices, getting it right every time. That's why I call it they are non-negotiable. So with that, let's start with this quote from Florence Nightingale. 100 plus years ago, she envisioned the first and foremost principle that we abide by is we do seek no harm. And that's what we promised when we became nurses also. So we want to live up to that promise, right? But 4 in 10 patients, they are harmed in primary and outpatient healthcare. These are all from WHO, highest avoidable medication harm occur 17 percentage in elderly patient care and highly specialized surgical care. So what I am trying to tell is that there is harm continuously happening as we speak now. We don't have the numbers in India, but we know that almost 99,000 deaths been because of medical errors, not just nursing, in US alone, but we don't have any numbers. So friends, are we ready to start the discussion and make some promises to yourself? Can I see some answers in the chat box? Are we ready? Yes. So let me hear that enthusiasm by saying yes, 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 yes. Lovely, lovely, lovely. It's nice to know. I always say nursing is a very passionate profession, but a very serious profession. But we don't need to be serious. We can learn in a relaxed manner. That's why these webinars are being conducted by Nurse India and Cigna Healthcare, just to see that we are able to understand the gravity of our profession and what we have gotten into. So let me just share with you this video. Uh, I hope somebody needs to ensure, tell me that you can hear the audio also.
I'll never forget the day that my 4-year-old son Logan
You're all able to hear it? Yes?
Yes, ma'am.
Okay.
Yes, we can hear.
Thank you.
almost died in my arms in Royal University Hospital. We were sitting on his hospital bed when he let out a scream. And I knew that he shouldn't be screaming because he shouldn't have been in any pain.
A bag of potassium that was a concentrated, heavy concentration bag was hung instead of a diluted bag.
As a pharmacist, I know that when the concentration of potassium is too high, that it can burn. So I knew when I looked behind me and saw potassium hanging that the concentration Logan had been given was too high for him, and as a result could have killed him. I immediately locked his IV and I started to cry and shake with all the chaos going on around us.
I went over to the bedside and saw that she clearly was upset about something.
And he looked right at me and he said, "I have no idea what you're talking about, but I trust you and I know that you know there's something wrong. I'm here to help. Let's figure this out."
We rolled Logan down to the OR waiting room where we met up with the anesthetist. And come to find out, he didn't even know that Logan had a kidney condition. He wouldn't have required us to increase the potassium if he had known that in advance.
I firmly believe that everybody that day was working with my son's best intentions. I work in the system myself, and I saw errors. I've been involved in errors before, but the way Saskatoon Health Region handled this error has been incredible to watch. Their openness to understand that there are safety defects in the system and their openness to work with me and to try to fix them have been unlike anything I've experienced in my own healthcare career to this point.
The most important thing that I learned from this whole experience was that, first of all, we as healthcare providers need to talk to each other. We need to be able to listen to the families. If we are in a situation where we're not sure what's going on and we're not comfortable with the situation, we can't be scared to just push the stop button and figure out together what's really gone wrong.
Safer Every Day is a 90-day initiative where we are focused on improving safety for patients and our staff. One of the areas of focus is on team communication. We're really working on how to help teams communicate, including the patient and family, in a way that keeps everyone safe. The other area we're really focused on is how do we support both the patient family, the staff, and the physicians who are involved in events like Logan's, so that they feel supported after the event, that we all learn from the event, and that we work together to put in initiatives or improvements that make our care safer every day.
I was devastated when I heard Logan's story, but I also know that unless we figure out how to work differently and build safer systems, that what happened to Logan could happen again.
May I request everyone to please mute your mic? I know your kids may be sitting with you, but keep your mic muted so that, whatever sound they make, it's not heard. So it's a kind request. I don't want to mute everyone just like that. So please make sure that your mic is muted. A humble request. Okay, ladies and gentlemen, what do you see in the screen and what does that picture mean to you? Can I have some answers? Your thought, there is nothing wrong and right, in the chat box. What do you see? Let's hear some, get some answers. Yeah, I am able to get some answers. Okay. Near to miss, gap. Okay. Anything else comes to your mind? We have good numbers here. So we should also have more thoughts around the picture that I just shared. Yes. Either you are paying attention or you are not paying attention. Only one answer came, near to miss, escalation, communication. Okay, okay. There are different meanings that are coming. Maybe, probably you are relating to the topic that I am going to talk about. May I request everyone to mute yourself, please? Otherwise, we will be forced to remove you from the session. Monica Chaudhary, please mute yourself. If you are not ready to be in the session, please feel free to leave. Let's have people who are interested to listen. This is a kind request. Please do not disturb the people who are here. Thank you very much. Can you see my screen? Can someone just confirm? Indrani, can you see my screen?
Yes, ma'am.
Yes.
Thank you. So I put this picture here. My intent was to share the story, the accountability of a nurse. This hand depicts life and this hand depicts death. So whatever we do and whatever we don't do can make a difference between life and death to another human being. That's the huge responsibility that we are carrying in our profession. That's what I wanted to start with. Look at this graph. Reported sentinel events, June 2010 to 2023. And the graph is kind of, similar number of events. And during 21-22, it did go up. These are some of the data which are available. I wish I could bring you some data from India. Unfortunately, no. But we also know these are sentinel events which have been already reported. I am not going to deep dive into near miss and no harm events. They are the iceberg, which is going to be discussed tomorrow by Dr. Jyoti Clara. This red one is right on top. Everybody reports, everybody comes to know about it, and everybody says, wow, this happened. We learn from them. But there is this iceberg that is sitting to be explored and learn more. So we'll learn more about that tomorrow. The reasons for all the sentinel events. You can see the top 3 things. This is very important for the leaders who are sitting here to understand that earlier communication used to be right on top. Leadership was somewhere down here, Before, I think 2011 or something, when I looked at this is the leadership was somewhere down here. Now it has gone all the way up, and the human factors is standing right on top. So when we look at errors or mistakes, these factors are very important to be captured, to be discussed, so that we don't penalize and only focus on the person, but on the structure and the process. And look at this, all the students and, frontline nurses who are here today in the webinar. Look at that. Communication is the 3rd most common reason for sentinel events. Sentinel events, by definition, are those unexpected events that lead to major disaster in patients, even up to death, all leading to injury. So there are many such events. Today's session is not about sentinel events, so they are all waiting to happen. I would like you to watch this little video also before we get into it.
Every day, the NHS strives to keep its patients safe. In a perfect world, this would mean no patients would ever be harmed, but humans make mistakes. Treating the human body is extremely complex, and given the scale of the NHS, dealing with over 1 million patients every 36 hours, there are many reasons why things can go wrong. When things go wrong, the most important thing for safety is that there is a culture that encourages everyone to identify the underlying causes to prevent similar incidents being repeated. Unfortunately, there can be a tendency to single out the member of staff most closely involved with the incident and to focus on the incident happening because of them. That's the wrong approach, though. When a patient's safety incident occurs, it is rarely the fault of an individual knowingly behaving in an unsafe or reckless way. In the vast majority of cases, things go wrong because of failures within an organisation's systems and processes. People will always make mistakes, and so our processes shouldn't rely on individuals being infallible. Evidence from safety science shows it is wrong to assume that if people just try harder, they won't make mistakes. Experience from other industries shows that punishing people for making honest mistakes doesn't work. Resorting to blaming individuals is often unfair and is usually detrimental to patient safety. It can create a culture of blame, where staff are reluctant to report and learn from mistakes, and it leaves the root cause of the incident unaddressed, with the risk that more patients will be harmed by the same mistakes. We need to ensure that we are treating staff consistently, constructively and fairly. A Just Culture Guide has been launched by NHS Improvement to support managers to do this. The guide builds on the work of Professor James Reason, an expert in human error, and is based on the National Patient Safety Agency's Incident Decision Tree. It uses principles developed from decades of research into human factors, as well as feedback from patients, clinicians and experts. A Just Culture Guide sets out a series of questions and recommendations that will help managers to consider next steps for an individual if the investigation of a patient safety incident begins to suggest a concern about an individual's action. The guide does not replace HR advice or existing organisational policies. It should work with them, and if used correctly, the guide should set managers on course to make a fair decision about the next steps. It also provides a useful check against unconscious bias, ensuring all staff are treated the same regardless of seniority or staff group. The guide is consistent with the approach being taken by a number of NHS trusts to reduce disproportionate disciplinary action against Black and minority ethnic staff. Involvement in a patient safety incident can be very stressful for everyone, for patients and their families, and also for the staff involved. Therefore, it's important that everyone involved is supported and treated with respect, in a way that has the best chance to improve patient safety. Being open and fair helps ensure we are all honest about what went wrong and helps to keep patients safe.
Okay, I showed this video before I start. It emphasized the point that systems and hospitals, with their best intent, they will ensure the environment is right, there are safety protocols written down. So nobody is designing a hospital that will lead to errors. I showed that to say that the system, the leadership, everyone is responsible for a environment where safe practices can be followed. Today we are talking about the individual who is taking responsibility for the safety of their patients. What is it that as an individual nurse, as nurse at the bedside, and the students who are going to be nurse at the bedside, what can I do as a nurse every day so that I don't get caught into situations where I can make mistake? So these are some of the points that I have learned from my own experience of being a bedside nurse, being a team leader, being a ward sister, being a supervisor, being a CNO, being a group head. I have lived all the roles, and I think that there are some things I always believe they are non-negotiable. That means we cannot let go of that. It doesn't matter which situation we have to do it. These are like must habits. We should have these habits every time without giving any excuses. The first and foremost is the infection control measures. Every single patient who comes to us, they don't want to get any additional infection. So when we keep that in mind, what is it that I should know as a nurse? I must practice standard precautions for all patients all the time. And I had been doing ICN program from 2012, and I know this is a weak area because I do test. I give them test on standard precautions, transmission-based precautions. I always see a gap. We all learn this, but we do not master the basics. So please make sure that you understand the standard precautions in entirety and we are able to follow that. 5 moments of hand hygiene are not to be the only area for ICN to audit and report. This is for me to practice when I am with my patient. It's knowing the 5 moments, okay, that is gyan. Practicing it at the right moment is what going to make a difference to the patient. So, do I adhere to the infection control prevention protocols? Do I know what PPE to wear, when to wear? Do I know how do I keep my medical equipments and the environment in the right manner? And then, do I know my isolation precautions and my prevention bundles to prevent transmission? See, prevention bundles, everyone knows. I know that almost all the hospitals are, accredited and they have all these things in place. But when it comes to knowing why we do a certain step in a bundle, there is where the challenge comes. Invest in understanding the why of everything that you're doing. That's the only way you will remember I have to do this right, because if I don't practice that, this is what it, like, for example, just give one example. I'm not doing these in entirety. These are not the courses or trainings on a particular domain. I'm just putting together certain habits and practices that we must adhere. It doesn't matter what, which patient, where we are, they all deserve us to do the right practices. Now, just for example, why do we scrub the hub? My favorite question always, why do we scrub it for 15 seconds? Why not 10 seconds? Why not 5 seconds? There is an answer to that, right? If somebody has an answer, you can put it in the chat box. And this just have become so world famous. Everyone knows the 5 moments of hand hygiene. So when you are practicing, do I ensure that I am always doing the right hand hygiene before and after the right moments? WHO has come up with these 5 moments after extensive research. Rather than making a document which is of 50, 100 pages, they summarized this into 5 moments. If we practice that, we can keep our patients safe. Now, when a patient gets hospital-acquired infection, we do not write incident reports. When a patient falls, we will write incident report. When patient has got hospital-acquired pressure injury, we will raise an incident report. But patient, when they get hospital-acquired infections, we don't raise an incident report. But that's an incident for the patient, right? He's getting something that he was not meant to get. So that also deserves equal attention from all of us. Standard precautions on the right hand side, this 8 components. If you master this 8 components, I am very sure, along with the hand hygiene, which is considered to be the cornerstone of infection prevention, we can protect our patients from getting harmed by a hospital acquired infection. So this is very important to get it right and make it safe every time. That's a tagline from WHO. They coined this for, medication safety. But I have something else to talk about. Very important: when, how, and why. Maybe I would like to take some test points from our audience here. What could be this point? Let me at least, look at the answers. What is it that we are, you know, what am I wanting to do that? We used to raise IR for HAI harm. Very good, very good. Incident report for HAI, that's very good. If somebody is practicing that, fabulous. So what is this next point I'll be talking about? Any idea? I didn't get anything. Some guesswork? Patient identification, ladies and gentlemen. I am very sure that if I ask all the leaders sitting here, what is the common root cause for many of the errors or harm that happens? Is because of this one factor. And I don't have to go very far. I have my own stories where my nurses, they failed to identify the patient. When do you identify the patient? By the way, if you visit Signia Healthcare YouTube channel, there are lots of free videos on patient safety discussing all the IPSGs in details, questions and answers, what are the good practices. So please feel free to visit and make sure that your new nurses and your students are able to watch that. You can make it a kind of a CNE, and if you want, you can give a quiz after that. Give them credit for the time that they're investing in watching the video. Rather than you taking the class, you may just run the video. They're available free on our channel, so please do visit. So when we identify the patient, we identify the patient before every single procedures, invasive procedures that we do, we have to do that before any procedures, including surgery. Of course, before you transfer a patient, before shift handover, whenever the caregiver changes, these are very important points before you take any blood sample. So the when part, you should be absolutely clear that this is when I have to identify. Now, how do I identify? This is where the challenge comes. I have a lot of stories to talk about it where when we did a prevalence audit, we found a sizable number of ID bands where the details of the patients were not clear. Either they were washed off or, patient said, no ID. When I took bath, it went off. And he said, it has been like this for more than 48 hours. What does it tell me as a nursing head? That means for 48 hours, this particular patient was under high risk of a error happening to him because nobody identified the right way. How do we identify the patient? Very quickly. The patient must be involved. He should be asked, please state your name. And the second thing would be the file should be taken to the bedside. Giving medications or samples or whatever, the file is with you. The details, the name of the patient, UHID must match with the ID band.
இது பாரு இங்க வந்து உன்னோட ஸ்பூன்ஸ் வச்சுக்கணும். ஏய்,
Can you
இங்க
please mute
பாரு,
yourself?
இங்க வைக்கணும்.
Whoever is speaking in Tamil, if you are not free, please leave the session. You can watch the recording later. At least please do not disturb. Thank you. So you have the patient file, you have the ID, and you tell the patient, okay, can you please state your name? I'll say my name is Tankam. So ID band is here. So I'm going to do this and say, oh, hello, Miss Tankam. Let me match your information with the file that I have got. So this is Miss Tankam and your number. Read it loud. Involve the patient. So this is very important. How do we do that? Some of you might say, oh, I'm handling this patient for the last 5 days. Why should I do this every time? Believe me, it takes only 1 second of distraction that you can make a mistake. So we don't want to take that. That is why I call this as a non-negotiable safe nursing practice. And why do we do that? So that we protect our patients every time. Get it right, make it safe every time, because it doesn't make any sense if me as a nurse, if I say, oh, I have been a nurse for 5 years, I never made a mistake. This is the first time I made a mistake. The patient, it is not a statistic, it's not a data. It has happened. For them, the error is complete, 100%. So we need to get it right every time. This is very, very important to be kept in mind, right? So coming to medication safety is some of the very, very important, non-negotiables I'm going to talk here is never administer medication without confirming the 6 rights. I'm not talking about knowing yours 10 rights, 15 rights. That is all gyan. WHO talks about following the first 5 rights. It is very important that this is non-negotiable. You have to do that. Self-check is something that I have practiced whenever I was giving medication. I will read my order, and then I will take the medicine. I will confirm that I have got the correct medicine. Again, just before opening, I will check the label once again that I have got the right thing. Again, I will look at the order, that what is the strength that is given. So one safe practice that I always used to have is continuously, talking to the patient, or even if the patient is unconscious in the ICU, I'll be talking to my patient because they can hear. So for example, I'll be saying, "Oh, okay, Mr. Raghu, Mr. Raghu, that is your medication time now. I have used Idet or whatever that is required." Then I will say, "Okay, it is 10 a.m. and you have got tablet of your medication for BP, Telma." So like that, I'll be reading along with the strength. And when I take it out, I'll say, "Okay, we got your Telma 40 milligram here. We got your aspirin, this one here." So I keep on telling, and the patient is also listening to me. So that is what I call a self-check. And then when I'm giving to him, again, I'm looking at my file. It's almost minimum 2 checks. I used to do 3 checks. Self-check. I'm not talking about the lambda and the high alert medication where mandatorily one more person has to check with you. So please don't skip those practices. Now, as an individual nurse, always ask about unfamiliar medications. So if you don't know the medicine, make sure that you are asking someone, what is this medication for? Minimum information you can easily ask your senior or the doctor very quickly. "Hey, doc, please tell me what is this medicine for and what am I supposed to watch out for when I give this medicine?" And I'm very sure it's a mini lesson for you immediately. Explain the medication to patients and family, make them partners. It's very important. So that sometimes they are the ones who are going to correct you and say, "Hey, sister, this medicine was stopped in the morning because morning doctor did say that, let's stop this medication." And the patients are aware of this, that this instruction was given. Document immediately after the administration. I have seen lots of documentation errors because the nurses to document it at the bedside immediately after the administration. So I would always urge you that you take the medication administration record to the bedside. One of the common problems that we used to have was that when patient is discharged, the file goes for MRD, not to MRD, the doctor's office for typing the discharge summary. We found the nurses were using medications written in a chit or they are giving from their memory. These are practices that just cropped up. Nurses, they saw a problem and they never escalated, and they started practicing something that was full of risk. So when we came to know about it, so why I'm telling this is that as a bedside nurse or as a student, while you are learning, if you see any unsafe environment, for example, me as a bedside nurse, I know I must have my medication administration record when I am giving the medicine. But my MAR is not there. So I am going to escalate this to my in charge and say, "I'm sorry, I need my medication administration record to give medicine to this patient. Without that, I cannot." If the in charge says, "You have been handling this patient for last 5 days, I'm sure you know what to give," stop and say, "I'm sorry, I will not do anything from my memory. I need the MAR." If you can speak up, I am very sure your seniors, your supervisors will come up with a solution. Never resort to shortcuts and then later you make excuses to say, "I told this one." Just be firm. I can give you one thing. When you stand up for patients, there are very few people who can ask you why you are being so difficult. Be difficult for the sake of patient safety. Ask the right processes. So when we came to know, we told them that the medication administration record will come out of the file and stay in the ward, because almost all the medicines are available in the computer. Those secretaries can take the list from there. So we made it a process. The MAR will remain in the ward. So that is one practice. The next area of concern, me as a nurse, is my patients developing. Just give me, some people are waiting in the waiting room. Let me admit all of them. Okay. So pressure injuries and falls, these are problematic areas. Now, me as a assigned nurse, what am I supposed to be doing to prevent these two from happening? I'm just giving you some general practices that you should not, give up or do any shortcut around it. When you do your risk assessment, do it diligently. Please do not copy paste the Braden score or the Moore scale. Oh, I will see what the other person has written and I will write. No, I have taken over the patient. The patient is my responsibility in this shift. So I have to do my risk assessment diligently so that I know my patient. I should ensure the family and patient they are aware of the risk. One of the things that we stumbled upon when I was a senior was that many times the patient is not aware that this patient is at risk for fall. Patient is conscious, but no one told. Okay, sir, ma'am, we have assessed and we found that you are at high risk of fall. So please help us by not doing this. This was something I found out when I talked to people who have had fall. To ensure we will all say patient education and family education is done. All those processes are in the paper. But the question is, are those processes being, followed? Did they understand the seriousness of knowing? What does it mean by falling at risk? If required, you have to tell the patient, "Ki, sir, ma'am, you are at risk because of these factors. And if you step out without helping, without informing us, you could fall and you could even land up in severe injury." If the patient can understand, great. If not, the attendant must know, and they should know why is it important. They should inform the nurse if they are stepping from the bedside. Only if they know, they will be our partners. If we don't do that, they will not understand. We take a lot of things for granted. And remember, me as a assigned nurse, I will give my advice in my shift because patient is my responsibility in my shift. I cannot give an excuse. I thought the previous shift has given. I thought so and so has done. These are very common answers that I have come across. So me as an assigned nurse, I am going to make sure that I am educating my patient and the significant other about the risk that they are at. Identify the risk involved in your patient. Not only there are many other risk assessment that you do, but I'm talking about the major ones, which are nursing sensitive quality indicators. That's the patient fall and the hospital acquired pressure injury. Remember, medication that can cause fall risk is a weak area in almost all hospitals because more scale does not talk about medication. It talks about a heparin lock, IV, that's it. But there are many medications that can increase the risk of patient fall. They need to be educated. So you have to know which are those medications that are increasing the risk of patient fall in my patient. And yes, we are aware of all that, most of the, sedatives and your cardiovascular drugs like that. There is a list of drugs. So I would urge all the leaders sitting here, if your fall risk assessment tool does not include medications, please, at least recently I have heard that a lot of hospitals have taken steps to include medications in the risk assessment. So, knowing the medication, learning about the medication becomes a very important safety aspect for any nurse. Just don't start giving medications if you don't know about them. You can read about them, you can ask about them, immediately know the action, and then know what are the risks that is involved. So, know your patient, observe the patient surroundings each time you visit the patient. Every time you go to a room, to a patient bedside, the patient is at risk for injuries, pressure injuries, or falls. Scan the environment. to see that everything is in the right place, patient is, positioned rightly. Does the patient need any position change? Many hospitals have already introduced, 1 hourly rounds, 4 Ps, 5 Ps. Most of the stuff which is there in the evidence-based practices is available in your hospital. The challenge comes when what we learn and what we practice, there is a gap. And if you think there are situations that is stopping you from practicing that, escalate. Find help to make the environment safer. Learn your surgical safety protocols. Very important that if you are not exposed to it, please make sure when you start in a hospital, understand the surgical safety protocol and see that what is the practice in your hospital. Learn about the WHO surgical safety checklist. Couple of my advice: never take surgical consent. Never ever take surgical consent. It is the doctor's duty and they should be the one taking the consent. You don't take the consent. Never do surgical marking. That is also the surgical team's responsibility. You will never do the surgical marking. But ensure they're all done on time. If it is not done on time, you can ask for help from your seniors. Involve patient in pre-op, OT, and recovery. Now, this is something when I did the audit, that how the patient is identified in the pre-op area. So it's a very interesting, scene that you will see. Patient goes to the pre-op area, patient is on the bed or in the stretcher, and the ward nurse is, talking to the pre-op area nurse directly and saying, yeah, hey Nisha, this is the patient. He's for this surgery. The consent is here. The marking is done. This is done. That is done. These are the X-rays. They both are talking to each other, and then the patient is wheeled in. Where is the patient being involved? The same identification process has to happen. The receiving nurse, pre-op nurse, has to ask the patient, sir, can you please state your name? The consent. This is your consent. Can you confirm that this is the consent that you have signed and this is your signature? We are being the safety champions. Patient confirms the consent is taken. You can now ask the patient, can you please tell us what surgery you are undergoing? The patient will tell. If he says ki, oh, in Hindi, if he says ki mera टांग में surgery honi, you will ask which leg. Then you will check whether the site is marked, and you can ask the patient कि ये डॉक्टर साहब ने यहाँ निशान लगाया है. You are double checking the safety processes. Is it happening or not happening? Nurses are called as the safety soldiers or safety champions because we are the last mile protection, the last net the patient can have to ensure that no harm is being done to them. And it is so easy to involve the patient and the family. And many a times things are happening, they are just watching things happening between nurses and doctors, as though they are not even there. Keep your eyes and ears open. You will be able to see such scenarios in hospital. And inside the OT, if you happen to be OT nurse, please make sure the timeout is done diligently. Very, very important. Sign in and timeout are very crucial junctions where errors can be, stopped. Errors can be identified. And we will not land up with wrong surgery on wrong patient, wrong leg being amputated or wrong side being operated, or a completely wrong surgery being done. This is all happening because what we call it as, normalization of unsafe behaviors. So what happens today? I gave medicine. I did not check the ID, but nothing happened. Everything went well. No mistake, nothing. I will do it tomorrow again. Nothing happened. Third day also I will say. Then I get confidence to say, okay, I can do this. Nothing happens to the patient. Believe me, ladies and gentlemen, one day this malpractice of mine will force me to do a mistake because I was little distracted. So it really does not make it any worthwhile to do shortcuts. So we all have to rise up. And if you think that you are not able to voice, please tell your seniors. Tell them that I am seeing this malpractices. We need to do something about it. Yes, speak up. It doesn't matter that you don't have experience, you are a new nurse, you learned about it, and what you learned is not what you are saying, what you are seeing. You should say that this is what I learned, but somehow I'm not seeing that in practice. Can someone help me? Please do speak up. This is very important. If every nurse becomes courageous and confident and communicate, our world can become far more safer. When it comes to clinical handover practices, please make sure you are identifying the right patient together. This is not a drama, ladies and gentlemen. Use a structured tool, whether you use, I knowingly did not put is bar here because that tool, in my personal experience, did not work out for our Indian nurses. So use a structured tool, and I have created one tool that I think can work, and I have sent messages if people want to test it out. Initially, I called it that ISAT, and I now reduce it to AISAT, ISAT tool for clinical handover. And if someone wants to do a evidence-based practice, and can be one gift from Indian nurses to Indian nurses, maybe even abroad they might like to use it, but we have to approach it and we need to talk about it. How did that, practice made the clinical handover more safer? If any of the nursing heads sitting here is interested to do the evidence-based practice or a study with me, please do reach out. I would like to do a couple of pilots of that tool. Yeah, please do let me know. So take time and explain to the next shift. It is very important that you are explaining. Both nurses look through the file at the same time. These are my points because I always, when I was a critical care nurse, you're super duper busy managing the patient. I always used to look at the shift head time as my safety time. I feel more confident. There are two more eyes, two more ears, one more person looking at the file along with me. I mean, four eyes are looking at, because I will use the file to say, okay, this patient was admitted on so and so day. While I'm talking, I turn the pages and say, okay, today this were the orders, this has been carried out, this is pending. So incoming nurse is looking at the same file. I'm also looking at the same file. Either me or she, we will pick up and say, oh, okay, there were 12 orders, 11 of them have been ticked. The 12th one is not ticked by me, and say, oh my God, one tick is missing. I didn't do that, right? It has happened, but we were able to catch that missing point, because in ICU, the orders can run into big, long list. So it is important that both the nurses are looking at the file together, show all lines, tubes, and medications. It's very important that you are able to show the line, the IV line, the central line, arterial line, whatever lines is attached to the patient, whether it is the drain or the urinary catheter. It's the time to look. The urinary catheter is anchored well, it is connected to the bag. Four eyes are watching all these things together. So it is a very, very important, crucial junction where you ensure that you are handing over after checking everything. Say everything and then ask for clarifications. The incoming nurse should never say, yeah, okay, I'll call you if I have any doubt. No, ask then and there. When I used to give handover, I will tell the incoming nurse, please make notes, sir. Please write what I am telling you. Please write. I used to tell her, please write. This is pending or this needs to be followed out. Please write. That when I was a critical care nurse, donkey years ago. But today there are many other solutions which are available. One very important thing, once again, is involve patient and family. And here I would like to share a hilarious story where we had, trained everyone In Fortis, we used to have something called the nursing care bundle, which had shift handover as one segment. We train what all things they need to do when they are shift handover. They both have to go to the side, involve the patient, and do all that. Me as a group nursing head, I used to do audits and talk to the patients. So when I went auditing in one hospital, the audit was going extremely well. All the patients are very, very happy. So I happened to go into one room where this lady recently had a cesarean section. So I asked her, how are the nurses? And she said, my God, your nurses are so good that, I don't even have to ring a bell. They are always here. So that means their hourly rounding was happening properly. So I asked the patient, during the shift changes, both the nurses, they do come. They said, yes, they are always here together. I said, do they introduce themselves? She said, yes, yes. They always tell, ma'am, I'm leaving. So and so is going to take care of you. They are so good nurses. So I said, okay. While they are giving handover, are you able to participate, ask questions? Then she just smiled and said, I can't do that because they both talk in Malayalam on the side. And believe me, my CNO definitely, it was a big, revelation. So all these kind of things can happen when we decide to deviate from the safe practice. Please don't do that. You are supposed to involve the patient, and when we involve the patient, they can be our safety champions. They will tell, sister, the doctor told that tomorrow I am for this test. Then you may look and see that the order, it is already ordered or it is not ordered. So you are able to clarify with the doctor, is this patient for this? Or tomorrow when the doctor come for rounds, he will just shout and say, yesterday I had asked for this, why nobody wrote? Or the resident will be blamed or somebody else is going to be blamed. Always involve patient and family. I'm sorry that fully timeout from OT came from the other slide, so that is not important in this one. But speak up. Yes, please do speak up. So I did talk about making patients as partners. Make them your strength, not your weakness. It is their body, it is their illness that we are supporting them to get well and go home without any additional problems. So making them partners makes sense, right? Can you drive somebody else's car if you don't know driving? You obviously you will ask them to drive the car. It is their body. It is their body getting healed. So we must involve them, and they are the safety champions. If you teach them that, it is our responsibility to do hand hygiene before we touch you, otherwise you can get infection from the hospital. Can you please remind everyone? Don't you think that the patient will or the family will start telling the doctors and the nurses, sister, doctor, please use hand rub before touching me because they are afraid of getting any infection. If you teach them why the ID band is important, why the ID band should be verified, they will become your safety champion. So this is important. You can do this as a trained nurse. You can do this as a nursing head, as a CNO. You can do this as a complete hospital process. You can select the way that you want to ensure the patients are safer. For all the staff nurses and the students, learn all about the emergency codes. This is very important. This is a sample picture I have put where whichever hospital that you are joining or working, make sure that you are aware of all the codes that are there. So you should know what code is being called. Learn your MET, RRT, whatever is the emergency medical code for patients who are deteriorating, is RRT, or whether it is medical emergency team, MET, whatever that is being called. Learn your early warning score correctly and implement. Please remember, it is very important to practice your critical thinking, at all the time. What does this number mean to my patient? Learn also the incident reporting system. Learn about it and make sure that you are reporting everything, especially the ones that do not reach the patient or it has not harmed the patient. They are also incidents. So make sure everything gets reported so that one can learn from those, mistakes that were about to happen but did not happen. Next time, maybe it will reach the patient. And make sure that you document with absolute clarity. Please don't, start writing, you know, jargons or vague terms is not required. Document without delay. As I told you, after giving medication, document immediately. After taking the vital signs, document immediately. I mean, based on whatever, documentation you have, paper based or it is EMR or HIS, make sure they are written as soon as you get the time. When you're writing subjective, this is just a simple thing. If you are actually writing, use, objective measures, reflect skilled services. Don't use these work terms, document what you saw, heard, and felt and smelled. Don't. When I was a very young nurse, we were very young student. Our tutors taught us, if the patient says "gabrahat," please write quote unquote "gabrahat" in the nurse's note. Don't try to translate. That is the way we were trained, because "gabrahat" can be anxiety or feeling uneasiness or a doomsday feeling. It could be different things for different patient. So we used to write patient complaint of Gabrahat as Gabrahat only. So it is very important to understand the words, and if you cannot have the right word, try not to translate that. You can use the real word as such. In case you are writing subjective, records, make sure that you are writing all the relevant things. Now, ladies and gentlemen, tell me, here the fulcrum of everything. What is this? This time I definitely want from the team. Can I get some answers, ladies and gentlemen? What is this fulcrum I'm talking about? One new message, Shrikala, thank you very much. Out of 123 people, Shrikala is at least listening to my question. Thank you very much. So she typed the right answer. Yes, Shrikala, you are 200% right. The fulcrum on which all these things are moving around is definitely communication. Now, how do you make your communication concise, correct, accurate? How do we do that? English is a common language used in almost all the hospitals. Please do invest. To some of the nursing notes, when you see, I don't understand what is this nursing note. Receive the patient, vital stable. What is there to write vital stable? Vitals is already recorded. You don't have to write vitals is stable. Vitals are recorded. If there is any deviation, you have to write, right? For that, you have to know some basic English is required. So invest in learning English and then practice and practice. There is no other, mantra for this. If you want to improve your English writing and speaking skills, you just have to invest in learning and then you have to practice and practice. This is something I learned when I was 17 years old, and when I joined nursing, I learned that I have to master this language. So I did not give myself excuses because I wanted results in my life. I wanted to be the best nurse in whichever role I was doing from then till now. So I am continuing to study even today. Today I'm sitting and talking to you all about all this because at least in nursing profession, I did not give excuses. Maybe in personal life I would have, but not in professional life. Have I made mistakes? Yes, I had couple of mistakes, but I remember them very clearly. And I can tell you also, those days, if I made a mistake, it's only because I did not read my medication record completely the way I used to do. Read loud. Yeah, so I did not read. Actually, I saw digoxin 0.25 milligram and the tablet was 0.5 and I gave 0.5 to the patient. Once the patient swallowed, I again looked back and I realized, oh, I have double dosed the patient. I had to immediately tell the doctor. I was all over the place, and then the doctor said, please relax, nothing happened to the patient. You don't have to be on my head asking, what should I do? What should I do? But those two incidents, one was this, the other one was the Lasix, which I was supposed to give 80 milligram and I gave only 40 milligram. I'm supposed to give 2 ampules, I gave 1 ampule. Again, the moment I realized, I became very, very panicky. I told the doctor, the urine output is like this. And again, they told me, please, you did not harm the patient. You're worried. You learned. Just make sure. After that, I said, there is no way I am going to take my eyes away from my own safe practices. So, ladies and gentlemen, let's rise above excuses and the results will follow. And this principle applies not only in our professional life, in our personal life also. I had been wanting to write a book for years now. Now, you will ask me, why didn't you write? I have my own excuses. I'm too busy. I didn't get time. I don't like to type. I'm slow in, but I know they are all excuses and I admit that. So, what is the biggest challenge is to show up when your mind is making best excuses. So, it is very important when our mind is making excuses. I remember very clearly one medication error where my nurse came and told, ki, ma'am, the mistake happened because I had 8 patients. So I told her, I'm sorry that you had 8 patients, but that's not an excuse. I only want you to escalate and tell ki, hello, I have 8 patients. I cannot safely administer my medications. Escalate, speak up. Say that I need help. That's what I want. I want you to be worried that you could make a mistake because it is an unsafe environment. The more and more, bedside nurses start asserting, saying that the environment is unsafe and I could make a mistake, I'm very sure leaders, me, and everybody else will start thinking, how do we make the environment safe for you to be practicing safely? But we will only know if you speak up. So this is very important that you don't give yourself mistakes. So that was my last slide. And we would definitely love to see you all tomorrow. And we'll spend about 5 minutes on any question answer or any discussion. So join us tomorrow. Jyoti Clara talks about moving the needle, the hidden iceberg, all about near miss. We would love you to join that. And if you have questions, we can take it. And before I stop sharing, thank you very much for being here. God bless all of you. Be safe, nurses. So now the floor is open for you to ask questions or you have any comments. We try to keep it exactly 1 hour. We can take 2-3 minutes. Anyone would like to talk about it? I know people are logging out. That's fine. No problem. We still have 107 people. Yes. Would someone like to speak or make a comment or ask any question? Dr. Devinder wrote here very informative to budding nurses, but I would say it is always very informative for all categories of nurses, including people like me. Even after 40 years, for me, it is revision. Making my commitment all over again, whatever I need to do, I'm going to do to make our care safer for our patients. How can you reduce or prevent medication documentation error in repeated education? Okay, documentation error, as I told you, is first of all, try to understand why are they not documenting. It's a good conversation to have with the people to understand why is it that they are not able to document at the bedside immediately after administration. Try to understand what are their challenges. I would start from there and then find most of the time it could be the process that we have set in. As I told you, the file has gone somewhere. A medication administration record is not there. So we have to ensure those kind of hurdles are removed from the process, and it's best to start asking them. Counter check the medicine every time is the norm, or it should be high risk medication only. The counter check by another person is recommended for high risk medications and LASA medications. That is where you need one more person to check. But in real life, the dialogue will be like this: Didi, high risk medicine देना है. Didi will say, दे दो मैं sign कर लूंगी. Now, if this is the dialogue that's happening, then the process is written correctly. So if you make a process which is very difficult to be complied, you say that every medicine should be counter checked. You think that practically possible? No, it is not gonna happen. You know that, I know that. So ensure the process are designed in such a manner that people are able to comply with it. It's not that we write process on process, which is very difficult for them to even follow. So, very important. Self check is what I practiced, and that's what I will recommend. But yeah, when I have to give pethidine, when morphine, or anything like that, any of the high risk medication, I will have one more nurse to check because we used to use a lot of, inotropes and, antiarrhythmics. So prepare those, IV drips. I was lucky in one hospital, it was prepared by the pharmacy. Another, we had to do it ourselves. We had to have one more person. So we identified who is that one more person who should be. It was always the team leader who to make sure that they are available to counter check.
Ma'am, good evening.
Yes, good evening, Arya.
Ma'am, this is Arya.
Yeah, yeah.
So my biggest challenge still is, ma'am, involving patient
Hmm.
during medication and handover. Still, my nurses are not very confident. They feel ki if they ask or involve patient, there will be more questions. They fail into it. So it is really a challenge for me in my hospital.
So I think what we need to do is, you should get your in charges to kind of be there to support them. It will maybe a slow
Yes, ma'am.
process, you know. And
Yes, ma'am.
also, young nurses also need to be trained that some very sensitive information they cannot talk in front of the patient.
Right.
So they have to know what I should not talk in front of the patient. The regular, whatever happened in the shift and all. No, you cannot
Absolutely.
tell. So all these scenarios, even get them to have the confidence by allowing the team leaders and the in charges to actually role play and do the thing with them.
Sure, ma'am. Sure, ma'am.
Started such things in Fortis, I used to sometimes go with them and say, okay, see me, how I'm doing. Sometimes
Right, ma'am.
very shy even to just to say, hello, Mr. Sharma, my name is Tankam. It's like, what is this?
Right, ma'am.
Fancy thing. It doesn't matter. They have the right to know. Everything is written down. Patient has got so many rights. And you will
Right.
how many rights we violate when we do something.
Yes, ma'am. Sure, ma'am. Thank you for a nice session, ma'am.
Thank you. Thank you. Thank you, everyone. When we reach zero medication errors. Thank you, ma'am. Okay. Thanks, everyone, for giving me a thumbs up for the session. I really hope those who have missed the recording will be available on Sydney Healthcare. And please go and check out all the patient safety videos that we already have there and use that to educate your, nurses and students. Feel free. It is all there. Why don't you use it? and make sure that your life also becomes easier, that you don't have to sit and make presentations, talk to them, use them. Thank you so much, and thanks Indrani for supporting by
Hi, ma'am.
meeting people. Yes, who is that?
Ma'am, this is Hemant.
Yes, Hemant, tell me.
Ma'am, I have a query, like how we can improve hand hygiene complaints in with physicians.
Okay,
Can we,
good question. I can give you one straight answer is that start with the patients. That is the one thing that gave me better results because I became doctor's enemy anyway. We taught the patients that before anyone touches you, they have to do hand hygiene. So at least in the wards, patients started asking, and the doctors came and asked me, "Ki ye kya kaam kar rahe ho tum? What are you doing?" I said, "I'm sure, sir, that if it is your mother or father, you would like everyone to do hand hygiene before touching them, correct?
yes,
So why
ma'am.
not?" So physicians are not the only culprit. Please, I know it is difficult to get their compliance, but the only way to get them, easiest way is to educate the patient and the family. It is their right. It is not only the nurses, the doctors, the technicians, the physiotherapist, whoever is going near the patient. We should tell them it's your right. We are trying to protect you. Please speak up if we are not doing the hand hygiene. Two things I will suggest today if I go back to hospital, I will definitely do is educate the patient about the use of ID band, the need to identify them correctly. And we just have to tell two stories to them. What are the risk involved? And I'm very sure they will go after our people. Please do the right thing. But Hemant, for all this, you need jigar, confidence, courage to do it. And that's something I learned. I was speaking to someone who had worked with me many years ago. So he's a doctor currently. He was a CEO and now he's with a big consulting company. So he was talking about something and then he told me one thing. And this is not something to self praise, but to share with you. He said that you believed in certain principles and you always made it a point to speak about that. So people listen to you. The way that you showcased the need for something made sure that others are forced to listen to you. So that power is something all leaders have to develop. That how do so very shortcut. Always talk about patient safety. Don't blame them for not washing hands. You should only argue for patient safety. You should say, sir, I understand, but the patient is yours and mine. If they get any infection, we both are accountable, responsible. So that's the only reason we are asking you. Respect is an underlying, ethos you should carry when you handle anyone. It doesn't matter whether it's a junior nurse or a senior doctor. Live by the word respects. When you're talking to someone, speak respectfully. When they hear this tone of, we are trying to rule them, we are trying to teach them, then human tendency not to listen. But we are able to respectfully talk about what is in it for them also. So you are able to create a win-win situation. I hope that helped you, Hemant.
Yes, ma'am. Yes, ma'am. Thank you, ma'am.
You can always text me if you need more tips. I can give you, no problem.
Yes, ma'am. I have your number, ma'am. I will do that,
Okay,
ma'am.
thanks, Hemant. I think
Thank
Indrani,
you.
we can wrap up now. It's 8:19. Thank you everyone for participating. Okay, if the patient is sit in the floor after toileting, should we consider as fall, ma'am? By definition, any any position from the upright position, if they change position, it is to be considered as a fall. That's by definition. Okay, thank you everyone. Thanks.
Thank you, everybody.
Can we say bye-bye now? So thank you everyone. Bye. Hi, Madhusmita. Nice to see
Bye,
you.
ma'am.
So we'll
Nice to
see
see you.
you all tomorrow, 6:50 at least. We'll see tomorrow with another discussion from Dr. Jyoti Clara Michael or near misses. See you
Bye,
tomorrow.
ma'am.
Yes,
Bye.
ma'am.
Bye.
Cheers.
Have a safe nursing practice and safe leadership. I see a lot of leaders here. Let's go and make life safer for our patients and the whole day of nurses. Take care. Bye-bye.
Bye, bye, ma'am.